Welcome to Beyond the Textbooks, the Iconic Scholar podcast, brought to you by Scholernetics 360, healthcare's first mentorship and knowledge-sharing hub. Don't leave your professional growth to chance. Instead, leverage Scholernetics 360's innovative video conferencing platform to connect leaders and specialists in your field. Select a mentor who aligns with your goals and feel free to switch until you find that perfect match. Whether you're seeking academic guidance, career advice, or aiming to refine your clinical skills, Scholernetics 360 ensures you can connect with top experts anytime and from anywhere. Visit www.scholernetics.com to join Scholernetics 360 today, because your professional growth deserves more than luck. Welcome to the Iconic Scholar podcast. I'm your host, Andrea Kessler, co-founder of Scholernetics 360. Get ready to journey beyond textbooks and learn from healthcare's brightest minds. Each episode is packed with insights and wisdom from industry leaders, uncovering the lessons and experiences that shape their careers. Join us to unlock the secrets to your successful career and discover the innovations shaping healthcare's future. Remember, while we're here to educate and inspire, we are not offering medical advice, just fun, educational, and authentic conversations. Okay, let's begin. Welcome to the Iconic Scholar. I'm your host, Andrea Kessler, and I have my wonderful co-host, Eder Garavito. Hi, Eder. How are you?
Hi, Andrea. I am doing great again today. Thanks for having me. I'm really excited about our guest today. We've gotten to know him really well, and he has a lot of amazing things to say. But also, I want to give him a shout out because Steve has really been at the forefront of helping us promote Scholernetics 360 since the beginning. He has been somebody who has really been a fan of what we're doing. And as a matter of fact, he was at the forefront of our campaign. He let us use his picture to put on our campaign. So we really appreciate him. And I can't wait to learn more from him. But I'll let you introduce him, Andrea.
Yeah, no doubt. I'm so excited to get into some great discussions. I think we're going to have a lot to talk about. He brings a wealth of knowledge and experience. He has over 15 years practicing in physical therapy. He started actually as a PT assistant and continued on and got his doctorate in physical therapy, which is awesome. He is board certified in orthopedics, and he's also a fellow of the AAOMPT. And he recently started his own private practice, which I can't wait to hear more about. But the big news for Steve Goostree is that we have a book on the way for the summer. He's published. It's called From Goose to Tree, Chasing Away Everyday Aches and Pains. And it sounds amazing. So I can't wait for him to talk about that. But first and foremost, congratulations are in order because Steve found out today that he was accepted to complete a second doctoral degree at Bellin College in Green Bay, Wisconsin. Congratulations, Steve, and welcome.
Thank you so much. I'm so humble. I hate when people talk about me. So thank you guys so much. This has been a long time coming. You guys are doing a hell of a job. So yeah, I'm excited.
We've been waiting to talk to you for a while. So I can't wait to hear more about your book, about your business. But can you start from the beginning? Tell us how you got involved in physical therapy. I mean, you're a pretty impressive guy, I got to be honest. So I want to learn how you got to be Steve Goostree.
Thank you. Yeah, again, I'm very humble. I don't like to brag about stuff. So if you can keep the compliments coming, that'll fuel me a little bit more. But yeah, so started out as a PT assistant, grew up in the northwest suburbs of Chicago, and then I went down to SIU Carbondale for undergrad, and my major was kinesiology, and always was fascinated by the way the body moved, right? So what better profession than physical therapy to treat that, when there's pain involved. I was kind of not awkward, but I grew into my body way too quickly. So I was already like 6'3", 6'4" when I was a freshman in high school. So obviously I'm going to play basketball, right? Because I literally just had to put my hand up and stuff someone's shot. And I won a Lion Award for that and stuff like that. But I kept spraining my ankle. It's like a giraffe trying to walk for the first time, if you will. So went to a cool sports PT, worked on my ankle sprains, chronic ankle insufficiency. I think I created that. And then another thing that got me interested in more of the neuro side actually was we had these really sweet neighbor couples, and one of them had suffered a stroke. And so I would, after, going to school all day, playing, basketball practice after, and then I would eat dinner. My mom's amazing cook. I would eat, and then I would go over to cute little Arnold's house. We'll call him Arnold. And poor guy, his wife was sweetest little angel, but she was having trouble transferring him to bed because he had left-sided neglect, I believe. So then that was my job. We would chat a little bit, and then we would take him into his bedroom, and I would transfer him. And so I'm like, I need to find a career like this because I literally would leave there with like tears in my eyes. I'm like, they're so sweet, they're good people. So PT was just kind of natural profession for myself.
And so you moved in, you became a PT assistant. And how long did you work as a PT assistant?
For about 2 years at a satellite clinic for the Rehab Institute of Chicago. It was in Elk Grove Village. It was the Alexian Rehab Hospital, where then I later worked in the ER. So that's kind of cool how everything's connected, right? So worked for 2 years or so, kind of hit my career ceiling early on. And I had I had a diplomat of the McKenzie method as one of my main mentors, and just some awesome mentors. They're like, Steve, you got to go back to grad school. Like, we don't want you can't be a PTA your whole life, right? So I was torn between, I shadowed a bunch of PTs in different settings, and also PA, because my mom was an advanced practice nurse, and she was kind of encouraged, like, become a male nurse, or a PA, one of those, because it was definitely in my blood. My grandpa was a surgeon and a hospitalist, and then my grandma was his assistant, and then my mom was a nurse in the ER. My dad started out as a firefighter paramedic, so they met in the ED because she thought he was handsome, and he was good with the pediatric patients. So here I am. So yeah, kind of a cute little love story there.
I love that. So you come from a medical family.
Yes, and I have two siblings. One brother that's he's a great businessman. Hates even if I say the word blood, he like cringes. And then I have a sister, younger sister. So I'm the perfect middle child. I like to say all the middle children listening will get that right. But yeah, she's a teacher, and we're all so passionate about our professions and careers and stuff. So yeah, so I was the one that was got the healthcare gene.
Andrea, I knew that Steve and I were going to be best friends. One, I did a kinesiology degree as well. And two, I'm the perfect middle child. But I'm curious about one thing, Steve. So you mentioned you did a kinesiology degree. So did I. My impetus behind doing a kinesiology degree was just like yours. Like, I like how the human body moves, right? But I didn't really have a plan for what I was going to do after that degree until about almost my senior year. And fortunately, I picked PT and I got into PT school, and, my stars aligned. But at the same time, when I reflect on that, some of us pay, if it's a private undergrad, like several thousand, $100,000 for that degree. And there's not much to it. Like, you could do PT, you can be a chiropractor, personal trainer, or a PE teacher, right? Like, it almost kind of is an empty degree. Like, did you know that too while you were in it? Because I didn't really know that until sort of the tail end of my studies.
I did kind of know that. That's why. So my junior year, I joined on at SIU. They had a PT assistant program, which, that's usually a 2-year degree at a community college. But SIU is a well-known research facility. So we were attached to like the campus health center, which is really cool. So then even as a PTA, I got to observe the PTs treating folks that came in with musculoskeletal complaints and stuff. So I partied hard. I'm a retired frat star, but I also worked really hard in my BS and kines, and then junior and senior year, did the PTA program and got the hell out of there in 4 years, because my parents are like, we'll help you out financially, but if you go past 4 years, you're on your own, pal, So kind of that tough love that kept me in the library, but also the bar.
So you had these amazing mentors that pushed you towards a DPT, right? Pushed you to go in that direction. I guess for me, I'm curious to know, you get that DPT and you start working. Like, did you stay where you were, or did you move on? Did you go back to where you worked as a PTA? And if you did people look at you differently from a PTA to a PT?
Sure. No, that's a really good question. So then, yeah, I did, I make fun of myself. I'm a job hopper, but I get bored easy. So if I'm like, all right, I've had enough here, would usually try to stick out a job for a year. And then it's always like, what's next? What's next? Right. Because I have terrible ADHD. So I can't even sit still. But yeah, so it was cool. I started in a small private practice, staff PT, which I kind of hate that term. Like, what is that even? Staff PT? Okay. I feel like that's kind of a slap in the face. It should be like doctor of physical therapy, PT, but anyway. So yeah, so then the former company I worked for through the Rehab Institute of Chicago asked me to come back and do a pilot in the emergency department. And That's where my mom worked. People knew my grandpa. So it all came like full circle. So I did that PRN. I would go there like Tuesdays and Thursdays and work like a 5 or 6 hour shift while I was still working as a staff PT, air quotes, and outpatient ortho because I'm obsessed with MSK pain. So yeah, great question.
So once you got there, where did you get into moving for your board certification and then fellowship?
So I was doing the ER even before my OCS, but that got kind of old. It was in the suburbs. I was living in Lincoln Park, Chicago at that time. So it was a pilot too. So I think I signed up for 6 months just to see how would go, kind of build the program. And based on my reputation, everyone knew my mom or my grandpa. It was crazy. Like people would even say, like they would call my grandpa's name is Tom. So they'd be like, thanks, Tom. And I'd be like, what? And I'm like, why are people calling me Tom? But then it's like my grandpa and I have the same mannerisms and we look alike. So it was freaky, but it was also like, oh, they mean Tom Salmons. This my grandpa, who is an amazing person and physician, one of my biggest role models ever. So yeah, so did that. And then I wanted to do residency, but I went to Franklin Pierce University and Josh Cleland was one of my big mentors out there. If you know anything about neck pain, back pain, like he was one, basically like manipulate the T-spine for neck pain and you're going to be slam dunking it. So big shout out to Josh. He's like, yeah, he knew Carol Courtney, also another rock star PT that she had headed the UIC, University of Illinois at Chicago fellowship here in Chicago. So he's like, Josh is like, do the whatever, 2 years that you need to actually sit for the OCS. Do your OCS exam while you're in fellowship because you're going to be talking about the CPGs and stuff anyways. So yeah, that was a hell of a year. I think I lost 20 pounds due to stress, but it was well worth it.
So let me just make sure I got this. So you did the fellowship. You didn't do any residency prior to the fellowship.
Correct. It was kind of a caveat. Carol said, all right, myself and my buddy Justin Lance didn't have our OCS yet. And now he's teaching at USC, which is awesome. Shout out to Justin. He's a great dude. So yeah, so they're like, we'll accept you, but you have to sit for the OCS at the same time. I'm just like, whatever. I'm like, bring it on. Like Josh says, what's next? So let's knock out 2 birds with 1 stone.
That is awesome. I mean, do you know how many people they dream to do what you've done, but they don't have those mentors? Being where you were very fortunate to have amazing people to push you and guide you forward. I mean, that's just what it sounds like to me. Would you agree?
1,000%. Yeah, that's such a big part of even my personality. I always had very, very positive role models and mentors to look up to. So that makes a world of difference.
Steve in the beginning mentioned after your amazing introduction that he doesn't like talking about himself. And I'm the same way. I swear, like this is why we're best friends now. But I'm starting to learn, Steve, through coaching and through working with our amazing team. We need to talk about ourselves as well, and there's no shame in doing so. And Andrew just mentioned, how many people would kill to do what you've done, and I don't think you understand how many people would kill to be in your position. And not only that, to literally look at all the accolades that you have and all the things that you've done, maybe partly due to your ADHD, who knows? But like at the same time, I think you need to just take a step back and celebrate yourself, brother, because you have done a tremendous amount of work already, and you're not even halfway through your career, and it's impressive.
And you're starting another terminal degree or a doctoral degree. That's huge.
Yeah, you can call me insane because doing the same behavior over and over again is insanity. But I'm insane, I guess.
I guess so. But, Andrew, I'm afraid to ask him what the end game is because I don't think he has an answer.
I kind of hope he doesn't because, Steve, you are a leader. And we were talking prior to starting the discussion we have going on now, and you're focused on your thesis and maybe your dissertation on PT emerging role in emergency care, right?
Yeah.
You're expanding our profession with your studies.
Yeah, I like to think I have some other really awesome, colleagues. Rebecca Griffith is huge with, pushing PT should be at the top of scope. She has an awesome book. Everyone go check that out, Top of Scope. But yeah, that's the thing. We need to be more bold, I feel, as PTs. Like I don't care what the doctor's order says. Like I mean ultrasound when I say ultrasound. Like I've gotten the craziest, requests from physicians. It's like, no, And then I love those stories. Like Adrian Lowe did a study on a detuned ultrasound, but it's all about the, patient perspective. If they think it's going to help, it's going to help, right? But why wouldn't we have a PT on the sidelines at an NFL game, in the emergency room, at urgent care? Like, we are the neuromusculoskeletal specialists. We need to put on our big boy pants and start acting that way.
Do you think we hold ourselves back because we're not being forthright?
Absolutely, Andrea. Yeah, I feel like we get in our own headspace, our own way, because we've always been more of a technician. It's like doctor, nurse, therapist, and then you work in acute care, and the nurses are screaming, "You go walk this person. You go change their diaper." You know. So I've seen some crazy stuff, but yeah, I think we just need to be bold. Learn how to manipulate the upper cervical spine. Learn how to do dry needling in someone's calf if they need it. Like, obviously with sound clinical reasoning and safety first, but we need to stop. We need to get out of our shell and be like, hey, we deserve to be primary care providers for sure.
In my background, Steve, is in acute care. That's most of my practice. And sure, I've changed depends and everything of the like, but I think there's something to say that if you're going to do that, you have to do it in a functional way so that it becomes a functional activity, right? And so when I teach my acute care course, I always teach the students, like, you're not walking a patient. Are you going to walk with a patient? Sure. But while you're doing that, what things are you assessing or working on, right? And so I do agree with you. And Andrea and I were just talking about this not too long ago. I agree with you that I think we narrow our scope too much sometimes. And therefore, we sort of try to hit this bullseye instead of casting this wide net like you're proposing, right? But do you think that we tend to compare ourselves and or compete too much or not enough with our physician counterparts?
I don't think we give ourselves enough credit, to be honest. Like, when I was in the emergency department, I had one physician that was obsessed with me because he saw me treat someone, this whole play test, and then a really quick, the barbecue maneuver. And then they stood up and he's like, what the heck did you just do, man? Like, so I think we need to be bold. We need to put ourselves out there for our counterparts to actually respect what we do.
And where do you think that starts? Like, where do you think that should start? Just for clarity of my question, should it start once you're a practicing clinician, once you're a fellow, once you're, you have a board specialty, or should it start while you're in school?
Personally, I feel it should start day one in your DPT curriculum, saying, congratulations, you're buckle up. This is going to be a wild ride, but you're a primary care specialist. So kudos to you. Study your anatomy hard, learn those manual skills, do the neuro tracks, do your cardio, all that good stuff, because you're going to make a huge impact in a lot of people's lives, and you're going to network and you're going to have a lot of fun.
But when we get out in the clinic, it's very different.
Yes.
We are then told that we have to cater to the referral source and don't upset them. And then we almost go against what you were talking about earlier about being bold. We're pushed down, we're stifled. And then we are no longer critically thinking. We are just going through the motions. And now we're getting to a point where we're just trained PTs how to follow what the doctor wants and not really thinking and treating and healing our patients like we were trained. And so we lose those skills, and then our profession overall hurts. But at the same time, we develop burnout because now we've lost that clinical creativity, if you will, and we need that. So I guess I say that because I see it. I was in clinical education for almost 10 years. Students would call me after graduation and say, I hate working. I hate this. Even in clinic, they would say that because their CIs would say, no, don't do that. Don't go against the grain. I know you're right, but we can't do that because we can't upset the doctor. And this is not a conversation against physicians. Please know that. But I've even seen it with other PTs. If there's a seniority issue and you have an older PT, or not older, more seasoned PT on staff, and they kind of rule the roost, the
Right.
newer PTs who might have a little bit of a better approach stay quiet. And that's problematic for our profession. So I guess, have you seen that? Is that something you've experienced? And how did you overcome it if you did?
My brain is going like a million miles a minute because I have like 5 different responses to that question. But yeah, again, be bold. I remember when I was a PTA, we would get a fax, like snail mail, and it would say hum on the top, which stood for hot pack ultrasound massage. That's what the physician wanted the patient to get for back pain. And I used to like tear those things up and throw them in the shredder. I'm like, this is ridiculous. Like, no, And then one other thing, I feel like we should all be allies to each other. But then you go to the AAO and PT conferences, and the McKenzie guys are here. The spinal manipulation and dry needling guys are here. The pain guys are here. And it's like a pissing contest. But at the end of the day, we're trying to make a change in people's lives and how they move and function. Like, why it's all guru silliness that I think we need to get over ourselves and stop trying to reinvent the wheel. And I love the big three M's, McKenzie, Maitland, Mulligan. Like, they do, at the end of the day, they're doing the same thing in terms of manual therapy. So let's all be friends here. If we got enough enemies as it is, chiropractors, massage therapists, PTs now saying that they're DPTs with dynamic physical therapists. Have you seen that coming out of Lifetime? Like, oh my God. So don't even get me started on that because I'm going to get fired, but I'm going to fire myself. The PT profession, like, up in arms, right? Because they call themselves dynamic personal trainers. So it said DPT, huge. And I like to play devil's advocate a lot. So the other day there's a brand new, beautiful, looks like a resort style Lifetime here in Chicago. And I asked the guy on purpose, I'm like, what do you think of, I kept saying, I'm a DPT. It's like, oh, you're a dynamic personal trainer. No, I'm a doctor of physical therapy. Face turned red and he's like, all right, we're going to end this tour early. I have a new meeting that just came up. I said, interesting, pal. Do you know much about this controversy? I know there's like petitions being signed.
I know a little bit about the controversy, not as in depth, and I know plenty about Lifetime Fitness, and I have been a consumer of Lifetime Fitness before, from a different perspective, right? But you just said something super interesting that I was just privileged to give the keynote speech for our white coat ceremony, and the message that it was built around was to stop this cutthroat mentality that we're developing in healthcare and work together, because ultimately it doesn't matter what we do, who we do it with, and where we do it. It's not about us. It's about the patients. And Andrew and I were just having a great conversation, not, just a little bit ago, about how some people, some clinicians sort of stick their neck out there a little bit too much and try to be who they are not. And they sort of taint our profession. And, when you mentioned there's the McKenzie people and there's the pain people, it's no shame on the groups themselves or the people, but like, that should not be the case. Like, we need to help each other out. And if we help each other out, hypothetically, if the McKenzie people don't know anything about pain, they can teach them about the McKenzie people about pain. And guess what happens then? Better patient outcomes. But we just are selfishly all the time. I want to be the best. I want to do all these things. It's almost like keeping up with the Joneses in some capacity. And we forget who we're doing this for.
Absolutely, man. Yeah. And it's, at the end of the day, it's a money-making Ponzi scheme, because like, oh, you got to take part A, B, C, and D, and E to get credentialed. And then you could, it's like, come on, man. Let's improve our DPT curriculum so we can have a little McKenzie knowledge, have a little Maitland, have a little pelvic floor, instead of like, oh, you have to spend thousands and thousands of dollars. You're going to make $70K coming out of here and you have $250K in debt. Like, something's off. You know what I mean?
Well, yeah, but back to your point about even your track, right? Going the fellowship direction, you got all that. Did they expose you to various philosophies and theories? McKenzie, Maitland, Mulligan, like, you were probably exposed to all of it. Your average therapist coming out, though, they're going to a clinic and you're hoping they have access to these courses. And let's be honest, these courses are expensive. I've done Maitland, I've done McKenzie, I've done Mulligan. They're pricey and they have a wealth of information, but you're hoping that people have access to these courses. And if you don't have the right mentor in place, or you have somebody that's pushing you in that direction, that's a problem. And so I guess, Steve, I'm going back to your iconic, because people are going to get something from this. Because I don't think PTs, one, with the high cost of education, students are coming out with lots of debt. And let's be honest, the healthcare systems that we have to work for, they're tough. I mean, you've worked for healthcare systems, right? And trying to keep up with their standard of productivity and then dwindling Con Ed funds, it's just getting harder for your average physical therapist.
Oh, big time. And that's the thing at when I worked, it used to be the Rehab Institute of Chicago, RIC, but it's now called the Shirley Ryan Ability Lab. And when I worked there, even it was right like around the time COVID started, I had a 6-month wait list because I was OCS fellow. I knew stuff about pain, and I was McKenzie. So I saw 8 to 10 patients a day that were chronic. Like, if you can work at the Rehab Institute of Chicago, you can treat anyone in the stuff that comes through that door is insane. I'd see someone with back pain, but they're a below knee amputee and they're on oxygen and they have a caregiver that doesn't speak English. Good luck. Like, what the hell? Just what am I treating here? You know what I mean?
Did they have a mentorship program there?
They did, which was huge. So everybody got, and again, that's why I really liked their model. I was assigned 2 mentors, 2 very different ones, a male and a female. One was a lot more kind of exercise based. The other one was more hocus pocus, postural restoration institute, whatever that stuff is. So it was interesting to see. I would take bits and pieces from that stuff, but again, let's keep it real. Like, someone's craniosacral, what fluid isn't moving when you put your hands on them with, like, you're touching a fly's wings. Like, some of the stuff is just very silly to me.
But it's good that you were exposed to a variety of ideas, because then you could make your own decision as to what direction you wanted to go as a therapist. And that's one piece that I like about your story. I also want you to talk to us about how you got to a point where you knew you were ready to start your own private practice.
So I always had the kind of entrepreneur like mentality. I started developing a big following with the patients I enjoyed working with. And then I would see them on the side. They're like, dude, I woke up, my neck is super stiff, it's locked, I have to travel this afternoon. Like, could you come over and do a quick manip and some needles, and I'll do some repeated retractions and we'll be good to go. So literally since 15 years ago, I started seeing people on the side because I'm much more about quality care versus quantity. And that used to just drive me nuts. If I had to get triple booked, quadruple booked, like, I'm like, I didn't go to school for this long to be told what to do. So then I would come back at whoever, the higher ups, like, oh, Steve, your productivity sucks. You're the most popular clinician here, but your numbers are terrible. And I'd say, okay, fire me then. So basically became unemployable, especially after the last debacle. I was just in virtual care, and I'm just like, I've already been doing this. I know what to expect. Let me get my LLC. Let's get a legal team and a business plan set up, and let's now treat people. And I'm not even 40 years old. Like by the time I'm 40, I want to be teaching, doing research, and educating and mentoring and stuff. So 2024 has just already been off to an amazing start. And again, sorry for rambling because I'm very passionate about this.
No, again, Andrea, another reason why Steve and I have become best friends. So during my practice, Steve, I fell into that same sort of dilemma, and should we call Steve an outcast? Well, because he doesn't want to follow the rules, and because he doesn't want to follow the rules, he did all these things. Well, I got threatened that I was going to have some repercussions many times because I didn't meet productivity. Yet my patient outcomes were always excellent, and my patients always talked great about me. So then there was this sort of like, well, you didn't see 10 patients in your 10-hour day. You only saw 7. I know, but I spent a lot of time with those 7 patients. And guess what? Like, they are doing great and they are doing amazing because of the things that I did. That is so often overlooked. And the thing that gets me even more wound up is the fact that most places use the 8-minute Medicare rule to assess productivity. And there's no correlation between that 8-minute rule and somebody's productivity. It's just a scale that is used to bill that is now used to assess how productive we are. It's just wild to me. So I did the same thing as you, Steve, pretty much in my own sort of humble way. I would be like, good luck, go to HR. They're not going to fire me.
Right.
I'm not doing anything wrong. I'm just not seeing 20 million patients, but I'm seeing patients and I'm getting great results. So good luck.
And then one thing that really just stuck out, this is kind of off track, but I had people tell me that my evaluations and then my documentation were too thorough. What? Excuse me? They're like, yeah, Steve, you could have done that 45-minute, very hands-on, very patient-centered evaluation in 15 minutes. I said, excuse me, you're not even a healthcare provider. I don't know what you are, but no, excuse me. Like, this is something's got to change.
Just from my background as well, I always attributed that as clinical bullying. So when we're talking about bullying with children, we all know there's bullying in healthcare. And I've seen it, I've received it in the healthcare setting, and it's a form of control. But then they
Yes.
go at you for doing a good job. I've seen it happen to other people. And that has pushed me out the door because I have an ethical compass that I need to work in a safe place. And unfortunately, healthcare bullying happens. This clinical bullying happens, and they go after you for being a good therapist and they mess with your head.
Yeah, it's clinical bullying. I love that term because you name it, man. But yeah, just then they put you on a performance improvement plan, and then they give you a written warning. It's like, I'm the number one. I make you guys the most money out of any of the 300 PTs at this company. Shame on you for coming at me.
I felt so bad for a colleague. This is when I started to plan my exit. We were allowed to work 10-hour shifts. So full time, you could work 4 10-hour shifts. Well, then they came into a situation that people weren't making productivity, back to Edder's point. And, we're seeing 8 patients instead of required 10, right? And it didn't make sense. But my colleague came to me, she was crying, and I said, "What happened?" She said, "I just met with our boss, and they are now requiring me to work 5/8s." And I said, "Why?" And she said, "Anybody who doesn't meet productivity has to work 5 8-hour days." And I was like, one, now anybody who works 5 8-hour days, didn't meet productivity. That is
That's
wrong.
embarrassing. Right. It's like,
Yes.
that's shameful. You're shaming the person in front of their peers. That's absolutely terrible.
So shameful. And she didn't last, right? She left because she was so humiliated. But it was sad because I watched the culture, a really good culture in that department, go by the wayside because of these clinical bullying practices that I saw with a new supervisor.
Wow. And that's all it takes is one crappy supervisor to let the whole company go to shambles. So, man, clinical bullying. I'm gonna have to write that down because that's
I just
definitely
did.
real.
I
Yeah.
literally just texted Andrea the same thing. And this podcast episode or the podcast isn't about me, but the more that I speak to Andrea here and then other guests and colleagues that come through, the more that I realize that I I shouldn't have felt guilty for not wanting to be a clinician since the day that I graduated PT school. I knew I wanted to do research. I knew I wanted to do go into education, and part of it was because when I was a PT student, I was very, very young and naive, but I noticed that I was paying a lot of money. I was missing out on weddings, on funerals, heck, everything. And I was just dedicating myself to everything. My girlfriend of I don't know how many years broke up with me. Thank you, Jesus, because now I'm married to a beautiful woman. But still, like all these things happened to me, all these trials and tribulations, right? And then I realized I am doing all this and I just can't work in a place where I'm going to receive a fax, like you said, or a piece of paper that tells me what to do. Otherwise, why am I in school, right? And that just sort of progressed eventually to the clinical bullying that I just told Andrea in a message. I was like, it literally just gave me closure because that happened to me so badly for so long. And I didn't recognize it until later in the game. And that's sort of what pushed me out of patient care. And now I still do PRN work, but I go in one day and I'm gone. And I don't think I could go back to full-time clinical care.
And geez, I wish I would have. I wish I would have coined clinical bullying because you know how many times I've gotten called in the office or this and this, and the damn manager can't even look me in the eyes when they're like, "You're getting a written warning." Okay, for what for? It's ridiculous, man. It's such a. That's why you guys are doing amazing. We're change agents. So let's change some of this stuff because we need physical therapists. We're here to stay. Whatever you think. But yeah, the clinical bullying. Enough is enough. It's great.
And you're completely right. And I'm going to give Andrea credit here because part of our campaign with Scholarnetics 360 was we didn't want to have endorsers or anybody endorsing us in the beginning that were huge names in education. We were having a conversation not too long, Andrea, right? That it sort of seems like, or PTs, I'll speak to PTs specifically. If a PT makes it into the world of education, they've quote unquote made it, right? And it's this facade that we give away. Oh, you're an educator. You're probably the best of the best. It's like, no, some are definitely not. Doesn't matter how many accolades they have. But Andrea started really pushing this envelope, and then she sort of surrounded all us together in Scholarnetics, and it's really been great because she's really helped us understand that we need to celebrate each other more, no matter how big or how small those accomplishments are. And that is really what we're trying to do. And that is exactly why when we sought endorsements for our campaigns, we did not have any huge published names on there. We don't care. You know what? It's going to happen organically. We don't really want to say we have this individual with all these initials and certificates, and then all of a sudden, they're just not good mentors. And that definitely happens. There's no correlation, right? So I love that too.
For sure. And I look back at all the mentors I liked, and even the feedback I've gotten from a lot of students are like, Steve is super chill. I was intimidated to work with him because he's got, talk about imposter syndrome. I have literally the alphabet twice after my name, but that's because I'm a dork and I like PTs. I want these certifications.
And imposter syndrome does come a lot with students and learners, right? And even with faculty, they look at us like we should know everything, and they are intimidated by one or two initials. When again, in all reality, there's no correlation, not a study out there that exists, and no subjective correlation even that somebody with all the initials behind their names like you do is a good mentor or a good educator, right? There just is not. Sometimes we use those initials and credentials on websites as marketing tools. Oh, this individual, this faculty member with all these publications and this CV that's 20 pages long, they're probably a great educator. When in all reality, they might be a horrific educator. They're just very knowledgeable, right? And so with that, and you mentioned your mentors and things of the like, and that you were lucky to have mentors, and then you got great feedback. Some of those mentorship relationships you had were assigned, right? Like, doesn't matter whether you loved your mentors or not. What I'm really trying to ask is, if you were to go back in time and take the same steps you've taken in your career, but instead of people assigning you mentors, you were literally able to choose them based on whatever qualities, accolades, requirements, skin color for that matter, identity. Do you think that you would have had better mentorship?
No, the more diverse, the better. And that's why my fellowship was so cool, because a lot of them were Australian. Like, they actually trained under Jeff Maitland. So then, I always liked the McKenzie method. That's what I was first exposed to. But then Maitland has such an awesome clinical reasoning model and subjective history and stuff. So I guess to answer your question, no, it didn't matter if they were male, female, as long as they were a nice person. Like, there's one that sticks out in my mind that I literally had to report to the program director because she was a bully and she was intimidated by me. Good luck. If you're trying to intimidate me, you're doing a terrible job and you're messing with the wrong person here, because I'm gonna turn it right back on you. But
good for you. And I agree with you, with the diversity element 100%. But what I was trying to ask more so, Steve, is like, if you were able to choose based on your own requirements at that moment, whatever they may be, diversity, ethnicity, anything, if you were able to literally say, Andrea, I like her because of XYZ, I want her to be my mentor. And you developed your own mentorship team based on your own needs, right? Do you feel like your experiences would have been better? Like, you just reported one that you said they weren't good.
To be honest, I don't think so. I think I like diversity. I like change. I like different people's opinions, and I learn just as much as I taught my mentors too. And same with students. Every time I mentor a DPT student or an ortho resident or Philip fellow in training, they're teaching me at the same time, and that's when I thrive. Because again, my ADHD brain doesn't sit still very long, and I get bored. So if you have someone that's very by the book, like, I like people again to be bold. So as long as they're bold, it can be, black, white, whatever, gay, straight, whatever you want. Just as long as they're teaching, that's all I really care about.
Yeah, and good for you. I mean, in my opinion, that's a perfect answer. And the fact that you just mentioned that you also taught your mentors, and as a mentor, you've also learned. That is huge. It's I think a big part of learning, and I applaud you for that, because oftentimes, once again, we go back to clinical bullying. We're met with those mentors or those educators or those leaders who are supposed to lead us, help us, mentor us, and instead they are just clinically bullying us and not helping us grow. Or when we know objectively as a mentee that we know more than them because of evidence, and they push back. It really creates just a negative atmosphere. So I think you've just hit gold mines with your paths, but also you in the driving seat as a mentee. I think that you have been literally textbook perfect mentee as well, and that's a huge part of that relationship.
You mentioned one other thing though, real quick, Steve, because you as a mentee, you identified that you have ADHD, right? And we've talked a little bit about imposter syndrome. I have had students who have had, dyslexia, learning disabilities, and I've always begged them to disclose that information to their clinical instructors, because that's something that we cannot disclose. I can't make them tell them, but The other piece of that is I sat through the credentialed clinical instructor programs, and nowhere in those programs do they go over somebody who has ADHD, somebody who has dyslexia. These are ways to help that student succeed. And as we're growing at Scholarnetics, we are working on a clinical mentorship program that will be available to all of our mentors. And they'll be encouraged to take the class and the program, but we will have methodology in there that will identify these are common situations and experiences that students have who have learning disabilities, who have ADHD, who've experienced, who have depression, the basic things that the average person deals with. But instead of coming at it like something's wrong with them, it's going to be this is what they face on a daily basis, and this is how we need to adapt the situation to make it better and more successful for them on their journey. And so if our mentors can have that awareness of how to structure conversations, structure suggestions, how they might be able to address these issues with their clinical instructors or their colleagues in their clinic. Do you find, or did you find anybody on your mentorship journey who identified that you had ADHD, or did you identify that you had ADHD with them and they responded based on your need rather than based on what you need to do?
Absolutely. And those are the mentors that stick out like, hey, I really vibe with Michael here. I want him to be my mentor more if possible. Because, yeah, and it goes back to my upbringing. I had amazing grandparents, and my grandma her name was Sheila. She had so many Sheila-isms where she's like, would always ask us, like, what do you think is going on in this movie? What do you think about that? Why? And then we would always get bad about it. And she'd be like, well, isn't it good that the world isn't full of just you and me? It's like we're all different. So again, kudos to my folks and my family. I'm a big family guy, but yeah, it's just, I don't know. At the end of the day, like, just put yourself in the student's shoes. You were there. You remember how it was. Like, no one wants to be hazed. No one wants to be bullied. That's if anything, that's going to piss them off. And then they're going to report you to the program director like I had to do. So yeah, and especially like being an OMPT fellow, like I was very kinesthetic. That's how I learned best. So I'm like, tell me in the most simplest way, keep it simple, Steve. Tell me what's the indication for this treatment? And then let's test something, perform it, retest. And then you give me feedback on how my handling skills were. And then I'd say 75% of the mentors were super open to me saying, hey, this is how I learn. I'm not the same as Joe or Tim or Chris or whatever,
I think that's important that mentors look at the individual. And clearly you had a supportive structure. But going back to that clinical bullying perspective, we are all different in the way we learn, right? There is no normal learning process. There really isn't.
Right. Thanks, Grandma, for that. Yeah, isn't it good that the world's not full of just yous and me's? Yeah, exactly.
It's true. It's true. And I'd love to hear your thoughts, and Ed, or you too. What I think is lacking clinically is clinical creativity, the ability to think about what is truly going on with your patient and being able to structure that session without the pressure of 3 patients an hour and productivity standards and limited resources. So I want to throw that question out there to you two. Steve, what do you think is the greatest limiting factor in clinical practice today?
It's all about the numbers. It's the quantity, not the quality, which I disagree 100% with. And diving into some yellow flags, like you got to have those tough conversations with folks. Like some PTs, I feel we need more psychologically informed education, because people are like, oh, I know how to treat it. I'm going to do all these tests and we're going to put on a treatment program. It's going to be simple. But one of my awesome mentors, Darren Earnshaw, always used to phrase it very elegantly. He'd be like, all right, well, besides your knee pain, how's life? How's your job? How's your relationship with your wife? How do you sleep? All those other lifestyle factors that are just as important, if not more important than biomechanics. Does that kind of make sense?
Perfect sense. Eder, I want to also hear your thoughts.
The first thing I want to say is, like, the more that we talk to Steve, the more I'm envious of the amazing journey that you've had, because it almost seems out of a fairy tale, to be honest. And I'm sure there have been, challenges and trials, and you've obviously been successful at all of them. But the picture that you paint is definitely is unfortunately, I should say, not the journey that most students and early clinicians have, in terms of the mentors that you met, the experiences that you've had, and such. And which leads me to answering your question, Andrea. First, I cannot wait, and I mean that so genuinely, for Stephen to join the education force, and not so that he can be some high-strung faculty member, but because I think he's going to make so many amazing changes and connect with so many students in so many different levels beyond what some of us can do, and you're just going to be amazing. But to answer your question, really, because I am on that educational side, the creativity, I think, oftentimes is stunted by things such as CAPTE standards and the NPT, to be honest, because not the CAPTE doesn't tell us what to teach, but they tell us, you got to teach around these standards. And then while we're sort of let free to be creative as educators, to teach students the things that we believe are necessary based on evidence and based on experiences in order to be a good entry level clinician, then we're met with the NPT. And what happens at that point is that now we have to ensure that we teach them what's on that exam, because it doesn't matter what we teach them in the middle. If they can't pass that exam, they'll never get to the point that they're going to be amazing clinicians. So we have to, as creative as we can be as faculty, we have to oftentimes tone it down, because we have to just settle for, okay, I really want to teach you this. I really think it's important for you to know this. Evidence tells me that it's important for you to know this, but at the end of the day, it's not going to be on your board exam. So we're just going to wait for another time. And so a lot of students are just graduate like robots, to be honest. And it's sad. And part of what I do in my courses is when they get to my courses, they don't get scripts for subjective interviews. Just like Steve mentioned, you have knee pain. I do that all the time. I don't work in orthopedics, right? But you have knee pain. Like, how are your grandchildren? Tell me about them. It isn't always about the ailment or about what you're going to do. It's about the person. And so then they get to my classes and I ask them to do a subjective interview. And they're like, well, can I like write out the questions beforehand? I don't say no. Like, I don't really care if you do, if you don't, but why? Why do you need to? Well, I need to know, make sure that I know what to ask. Just have a conversation, have a damn conversation. And if you miss something, come back and get it later, or come back and get it tomorrow. But treat the person as a person and be creative in the way that you do it, and understand that when I do a demonstration, that does not mean that's how you should do things. It is just a way to do things, right? It is not the only way.
Absolutely.
And we don't do enough of that. And then, like I said, we just sort of both ends a little bit held back. But Steve, you're going to be amazing educator, man. I cannot wait for you to interact with students and really just put more Steves out there, as bad as that sounds, in terms of, it sounds like little children, but not really, just really transform some of these students into amazing clinicians. And I think it goes beyond transforming them into amazing clinicians, Andrea. It goes much beyond that. It's more of the changes that you're going to be able to make through their minds based on the things that you teach and the experiences that you share with them.
Well said.
I love that. Thank you. Thank you, Eder. Thank you, Steve, for joining us. Oh, this was a lot of fun, Eder. I really learned.
It always turns out being so much fun, and we run out of time.
Yeah, we ran out of time, but Steve, I hope you'll come back. I mean, especially as you're on your education journey, toward your terminal degree. It's so exciting. We get requests for, at least Eder and I have in the past, from clinicians who want to know what it's like to, experience terminal degree. And I'm grateful that you're a mentor for Scholarnetics, because that's another area we can allow the mentees to get some insight and connect with people who've either earned their terminal degree or people who are in the process. What a great way to connect and grow together. But thank you, Steve. I really do hope you'll come back and join us, so we can keep up with you. Steve, part 2.
I'd be glad to come back once I get started.
And your book is coming out this summer, so we will be sure to share that with all of the listeners once that's available. So please,
yes,
we'll get you back here.
It'll be very affordable. It'll be like $4.99 or something. So don't worry.
Hey,
about it.
don't devalue yourself. If it's worth $20, it's worth $20, Steve. But we'll make sure to put all that information on the show notes so that anybody who listens can link up with you and also with your book and your entire journey, because I think I could listen to you for about 10 more days, to be honest.
By the second day, you would be like, get this guy out of here.
Challenge accepted, Steve. Let's do it.
Thank you for joining us on the Iconic Scholar podcast. If you enjoyed today's episode and want to continue the conversation, don't forget to connect with us on social media as @ScholarNetics360. Make sure to hit that subscribe button so you never miss an episode. And remember, always consult with a healthcare professional for medical advice. Until next time,